Welcome to The Explainer. Today, we're going to break down 3 new studies with takeaways so practical you can literally use them on your very next shift. We're going to question some old habits and give you the evidence to feel good about it. All right, let's kick things off with a classic. You know the one. The patient you've probably seen a half dozen times already today. For simple mechanical low back pain, we all have our favorite cocktail of meds. But what if one of the most common ingredients doesn't actually do anything? Let's see what the data says.
So here's the first big question. For your patient with straightforward, non-radicular low back pain, does tacking on a muscle relaxant to an NSAID actually help them feel better or get back on their feet any faster?
And here's the punchline, right up front. A really solid analysis that pulled together 4 different randomized trials found pretty much no difference. When you looked at how well patients were functioning and what their pain levels were a week later, adding a muscle relaxant to an NSAID was no better than just giving them an NSAID and a sugar pill.
Okay, just take a look at these numbers for a second, because this is what's so fascinating, right? They are so close. On this disability questionnaire, patients who got a placebo improved by about 10.5 points. Baclofen, 10.6. Cyclobenzaprine, 10.1. I mean, statistically, this is a wash. It's nothing. They all got better by about the same amount, whether they got a muscle relaxant or not.
And here's the other side of the coin, the harm. So we've established there's no real benefit, but there is a risk. Patients who took cyclobenzaprine were almost 3 times as likely to have side effects. You know, the drowsiness, the dizziness, all that stuff, compared to the placebo group. So you're looking at no upside and a very clear downside.
All right, let's shift gears. Our second paper is going to challenge a piece of dogma. I mean, something that's been hammered into us from day one of our training. You know the one. You've heard it a million times, right? GCS Lesson 8, intubate. But does that rule really hold up for a patient who is comatose just from an acute poisoning? A brand new trial decided to put this old classic to the test. So researchers in France set up what they called the NICO trial. And what they did was pretty bold. They took these comatose patients with a suspected poisoning and a GCS under 9, and they randomized them. One group got a watch and wait, conservative strategy, and the other got routine care. Basically, the doc on shift could do whatever they normally do. And the results? Whoa. I mean, just look at this difference. In the group where docs just followed their gut, almost 60% of patients got intubated. But in the group where they were told to hold off unless the patient got into real trouble, only 16% ended up needing a tube. That is a massive drop. And that has this huge ripple effect, right? Because in France, if you get intubated, you're getting a ticket straight to the ICU. So what happened? ICU admissions just plummeted from 66% in the routine group all the way down to just 40% in the conservative group. But here is the absolute kicker. This wasn't just about saving an ICU bed. The conservative strategy was actually better for the patients. They used this thing called a win ratio. And basically, when you looked at a combo of death and hospital stay, the conservative group came out way ahead. They got home faster with no increase in bad stuff like pneumonia or death. That's a huge win-win. And for our final paper, we're diving into what is, let's be honest, one of the toughest things we deal with in the ED right now, managing severe opioid withdrawal in the age of fentanyl. So you know the drill. Fentanyl is just a different beast, and our usual playbook with buprenorphine sometimes just doesn't cut it. The withdrawal is too severe. So some hospitals are trying a new strategy. They're using what are called SAFOs, short-acting full-agonist opioids. Think meds like oxycodone or hydromorphone to get immediate control of those awful withdrawal symptoms. So this hospital looked back at their experience using these SFAOs, and what they found was a pretty clear signal that it was working. As they carefully titrated up the dose of, say, oxycodone, the patient's withdrawal scores went down. It worked. They were effectively treating the symptoms. Of course, the alarm bell that goes off in every one of our heads is, wait a minute, is this safe? Are we just causing another problem by giving full agonist opioids to patients with opioid use disorder in the hospital? Well, looking at over 100 different hospital stays where they used this strategy, the rate of really serious oversedation, we're talking someone getting dangerously sleepy, was just 4%. That's it. Only 5 total events. And when you dig into those 5 cases, the story gets even more reassuring. 2 or because patients use their own drugs in the hospital. 1 was actually from methadone titration. And for the other 2, yeah, the SAFO might have played a role, but so did other sedating meds. The big takeaway here is that the SafeFoot protocol itself wasn't the lone culprit in most of these rare events, suggesting it's a pretty darn safe practice in a monitored setting.
Okay, so we've gone through a lot of data. Let's boil it all down. What does this actually mean for you tonight on your shift?
Here it is, your 3-point debrief. For that low back pain patient, stick with NSAIDs alone. Skip the muscle relaxant. It doesn't help, and it might hurt. For that poisoned, comatose patient, a low GCS is not an automatic green light for intubation. If their airway is stable, watching them closely is the better move. And finally, for that patient with severe fentanyl withdrawal, using short-acting opioids to control their symptoms is an effective and reasonably safe tool to have in your toolbox.
You know, what these 3 studies really show us is that medicine is always changing. The routines we were taught yesterday might not be the best thing for our patients today. So the real question to take with you is, what common practice are you going to question tomorrow?